you have many reasons for having an indication of operate bladder diverticulate. Could be chronic urinary infection, could be voiding dysfunction, and it can be a complication of the BPH. So we have a nice movie from Eric Mandron, who will be there tomorrow, and I will comment this movie. You can start.
49 ans, consultant.
So we will use a preperitoneal approach. You see, here first are the diverticula. You have two diverticula, and one is big and the other is more little. And you see when the bladder is empty, the diverticula is full. So we use a various needles and insufflate the preperitoneal space and then introduce directly the first trocar in this space which has been insufflated. And when you introduce the scope, you notice this specific aspect of arachnoid tissue. And with the movement of the lens and with the pressure of the gas, you create the space. We rapidly see the various needle in here, the various needle you can see. And when the lateral space are prepared, you can introduce the lateral trocar that you will need. So Eric Mandron is left-handed, so he used this monopolar scissor in the middle and a grasper in his right hand, and the assistant has a suction device. So we are on the anterior face of the bladder, and he's doing a vertical incision of the bladder to open the bladder. You can see the balloon of the Foley catheter. So you enlarge a little bit the incision to have enough space to work easily. We will fix the lateral part of the bladder wall on the muscle of the abdominal cavity. There are some specific devices that can be used, percutaneous device that you can use to help you to fix this lateral part of the bladder. So that the bladder will remain open like this. Then you can enter with the scope inside. You can deflate the balloon. And you will look for the bladder, for the neck of the diverticula. Here are the two neck of the diverticula. I think it's a good option to check the position of this diverticular neck from the urethral orifice. Sometimes you can have a diverticula which is very close to the urethral orifice. In this case, it could be useful to place a urethral stent, for example. Then you have seen, you incise around the neck of the diverticula, and progressively you pull out the mucosa, because the goal of the operation is to remove the entire mucosa of the diverticula. Around this mucosa, outside the bladder, you have a kind of pseudo capsule that can remain in space in the patient. But what is important is to remove all the mucosa. You can notice that he is using a hook there. Maybe this instrument can be helpful for this kind of smooth dissection. And progressively, by pulling on the mucosa, you see, it's coming out. In my experience, in some situation, you can be in the wrong space, and it's possible to remove the pseudocapsule also, but then you have the fat which is around the bladder, and even you have more bleeding in this situation. And I think it's better if you can remove only the mucosa like on this video. So it seems the diverticula is completely removed, and you can place it in an underbag. We do the same with the second diverticula. The next step will be to close the neck of the diverticula with a suture that takes the entire wall of the bladder, not only the mucosa, but also the muscle, to close the muscle, because as you know, the diverticula is a kind of hernia of the muscle part of the bladder. So you can use the running suture, you can use X point, interrupted suture, depends on the wideness of the opening. So the two neck of the diverticula are closed now. And in this patient, Eric Mandon has considered that there was a bladder neck obstruction, which was the etiology of the development of the diverticula, and he chose to perform a bladder neck incision, you see, by the laparoscopic approach. This can be discussed, and you can also incise the bladder neck by an endoscopic approach later on, or in a first step. It depends. Because as you can see, you have not a very good vision there. So maybe the endoscopic approach is better, but it needs a second surgery, of course. So the Foley catheter is replaced, and then you have to close the bladder wall with a running suture, taking the entire bladder wall. I think nowadays there is no space to make two layers to close the bladder. That was described in the ancient books, but now with the thread that we have and the vision that we have, that's the control with the cystography after the operation. So just one comment that this kind of diverticula, you can have also a transperitoneal approach for women who have not a diverticula which is too posterior. You can have your assistant with a cystoscope in the bladder, and who enter in the diverticula, so you can see the light when you are by a transperitoneal approach. And then you can surround the diverticula by approaching from outside the bladder and reach the neck of the diverticula. It's also an option that I have the experience of this. It's possible, and then you have to close the diverticula neck from outside. But it's only when the diverticula is not too posterior and too close to the orifice of the ureter. Do you have any comment about this option, this technique about diverticula? If not,